Hello there, and happy Wednesday to you. I'm going to see if I can share this picture with you. Yes, check that out. I'm so excited. I wanted to try this out with a little different technology so I could share the picture as I'm talking about it. And I think... Hey, Sherry. Hopefully you can see that okay. This is my first time doing this, but I wanted to share a little bit about how we go about assessment of functional movement disorders. I get questions a lot of, I'm seeing somebody with this, and this. Thank you for the feedback, Sherry. It's my first time. I never know what I'm doing on Instagram, to be honest. So thank you, Sherry. Sherry, another great movement disorder PT. I'm so glad you're here. So I get those questions, and I'm sure you do too, Sherry. Like, where do I start? It can all feel very overwhelming when there's a lot of different symptoms happening. Maybe there's a long history of different events that have occurred. Maybe there's motor symptoms, and there's tremor, and there's dystonia, and there's myoclonus, and it can be really hard to know where to start and to feel like you've hit all of your bases. And I love a good, systematic, organized way to go about things when they can be pretty complex or confusing. And this is where our functional movement disorders pie chart came to be. We actually, I want to say this came together a few years ago, and we brought it to CSM when Chelsea Richardson and myself and Carly Luckala, Mike Studer presented. And we brought this pie chart for assessment and for treatment, and now we have it for pathophysiology. By the way, on Friday, excuse me, I'll be doing a live on our Facebook page to talk about treatment. But this pie chart helps us organize our assessment into those underlying factors that really contribute to a functional movement disorder. So I won't hit on every little piece, and I don't know, you'd have to like really squint your eyes just to read them off of this. But by the way, you can, I posted our pie chart today. You can print it out, and you can see along the pie, we have those categories of motor control, the sensory systems, the psychosocial contributors, lifestyle, autonomic, and physical limitations. And just briefly, let me hit on all of those. Yes, I'm getting high fives to the brain all around here. And I think this is one of the tricky parts in the functional movement disorder, is to try to understand, where has the connection gone awry? We've talked a little bit about pathophysiology and functional movement disorders, and some of those key areas where we know the connection is abnormal, like temporal parietal junction, for example, supplementary motor area. These are coming up on fMRI. But how do we test that out? It's really complex. So around the pie chart, this is not the order you would go in, but just to think of these categories, in motor control, obviously we're going to watch movement, right? And see what maybe precipitated the movement, what came at the end. For example, I was working with one of our therapists today with somebody who has a functional myoclonic jerk. And we could see by watching really carefully, it started at the neck. Very careful movement analysis helped us discern where to start. So then we started actually then hopping into the sensory section of our assessment. We started hopping and testing sensory. So looking at joint position error, for example. And we found some impairments, but not a lot. So then we looked at the influence of things like vibration or tens on the neck and how that influenced the movement. And it was actually really quite profound influence. So these are, I think, as physical therapists, as occupational therapists, we're often looking at how people move, but do we go the next level with that movement and looking at their motor control, isolated movements, and muscle activation patterns, especially with dystonia and myoclonus? I find those really important. What about the response to feedback, mirror feedback, or biofeedback, or video feedback? We love flipping videos, especially when there's a unilateral issue. That can be a really interesting way to see how that motor imagery plays into things. And I think the biggest piece here, and Chelsea Richardson posted for us yesterday on use of optimal in FMD, we use this as an assessment. How does the movement respond to autonomy and choice? How does it respond to an external focus of attention? And how does the person and movement and symptoms respond to enhanced expectancies? You've got to do that in that initial assessment, and that will build a picture of an underlying motor control issue. I talked a little bit about sensation with joint position error, but we do a lot of looking at 2-point discrimination, tactile localization, kinesthesia. We go into those higher order pieces of graphesthesia, stereognosis, and moving into other sensations. Sound localization, for example, that can be impaired when our autonomic nervous system is involved. Looking sense of smell. Boy, we've been bringing in a lot of grounding to smells lately. Natalie, one of our therapists, had somebody chewing on cloves, which I was like, I'm going to try this because they're very distinct, right? So that was part of the treatment, but that comes from your assessment. Vestibular system, visual have to be a part of that sensory testing. From a psychosocial realm, this is where I love having a neuropsychologist who can dive in to both the emotional world, mental health world, cognitive world, and dig into some of this history, family history, trauma history, history of anxiety and depression. Overall self-efficacy, we know that agency and voluntary control is an issue, so this can have a psychosocial influence as well. And so being and having a part of our team, remember, this is part of my soapbox, functional movement disorders are not all psychosocial. That's just one piece of the pie, and you have to look at all of the pieces. And too many people have just been thrown in the bag of like, well, go see a psychologist and you'll be okay. But they can't control their movement. They should be seeing a physical and occupational therapist. And looking at things like lifestyle, this is where I'm so thankful that we have OTs trained in lifestyle interventions to look at sleep. Sleep deprivation is a big one. Having purposeful activities in their life that's goal-oriented, pacing, diet, stress management, and just overall participation. Huge areas of lifestyle that may be underlying the functional movement disorder and then become part of treatment. Now, autonomic, you've heard me talk about autonomic. I'm pretty obsessed with the autonomic nervous system. So we have to test it, right? So we look at heart rate variability. We look at orthostatic hypotension. We look at resting heart rate and heart rate response to exercise. We look at exercise tolerance overall. We're starting to look into, thank you to our amazing colleagues in Canada, actually, who have gotten us onto pupillometry as an outcome measure in the autonomic nervous system. So we need to test these things to see how big of a part of the pie is the autonomic nervous system. And then finally, and last but not least, are the physical limitations. So many people that we work with a functional movement disorder have had a physical accident or trauma that we also need to address and ensure that has had full resolution. So we see a lot of things like impaired neural dynamics, maybe just joint mobility, strength, their overall biomechanics and flexibility. These are things that we're used to looking at. But just because somebody has a functional movement disorder doesn't mean those things don't exist. So you have to look at the whole pie. So I think this gives you a picture of how thorough and how complete a full assessment would be with a person with functional movement disorders, looking at all components: motor control, sensory, psychosocial, lifestyle, autonomic, physical limitations, and then seeing how big each of those pieces are. And I mentioned this in my post today. The first place to start before you just dive in and put somebody through the paces of all of this testing is listening to their story. Every person I talk to has a tremendous story, and they literally tell me how big these pie pieces are. And in fact, we have an activity in our functional movement disorders workbook where the person creates the pie themselves, and we start there because the people I work with have great insight and wisdom into themselves, their bodies, and their brains. And if you don't tap into that to lead your evaluation, I think you're starting off on overload for sure. So use that person's story to hone in on those pieces of the pie, and then you can keep peeling away layers in subsequent sessions. But this is what we use in our intensive program for people with functional movement disorders. We use a very thorough assessment and bring that right into a treatment plan. And this is why we're so lucky that this is not just PT. This is our PTOT psychology assessment. And so we can really divide and conquer the assessment together. So I just want to thank you so much for being with me. And you know what? Your input and questions have been so helpful to me and my learning. If you have questions about the functional movement disorder assessment, send me a message. I'd love to chat about it and hear what you're doing as well. So thanks so much for joining me tonight. Catch me on Friday on our Facebook page to talk about the pie chart for treatment. And I'll catch you next week. Thanks and have a good night.